Hello, everybody. Welcome to another episode of Cancer Specialist Medical Minute.
With Dr. Rick and Dr. Danny.
I'm Rick.
And I'm Danny, and we're excited to be back for another episode of Medical Minute. Rick, you ready for another dad joke?
This is literally what I live my life for, is to hear these jokes. Literally.
Do you know what kind of music planets listen to?
You got me.
Neptunes.
Wah, wah, wah.
Okay, I got another one for you. Here we go. Let me bring it back to the top here. What is a chiropractor's favorite music?
Snap, crackle, and pop.
Close. Hip hop.
That's not bad.
Not bad.
That was a good one.
Thank you. All right, guys.
So, what are we talking about today, Danny?
Well, today's topic is pancreatic cancer, Rick. And pancreatic cancer is a unique disease. It's a disease which we'll talk about a little bit in more detail as far as the little bit of history behind it, some of the signs and symptoms of pancreatic cancer. Brenna gave us some statistics here. So it's estimated that about 60,430 adults will be diagnosed each year with pancreatic cancer. This accounts for about 3% of all cancers. So it's the 8th most common cancer and the 4th leading cause of death. So although less common, it is a leading cause of death in both males and females as being the fourth leading cause. So Rick, it can be a devastating disease for patients who get this diagnosis. And I know we'll talk a little bit more about how we both approach treatment. Do you have any specific, insights into this or some comments on it?
Yeah, my first comment is, I think like a lot of people who probably listen to this podcast, I personally, family have been affected by cancer and unfortunately pancreatic cancer as well. My paternal grandmother passed away from pancreatic cancer many years ago. So we got to see what you were mentioning with the statistics firsthand, kind of how it may not be the most common cancer, but unfortunately tends to be one of the most lethal. And we'll get into some of the reasons sort of, why that's the case, but it's certainly, I think, a cancer that even most lay people are aware is a pretty devastating disease in a lot of situations.
Definitely is, Rick, and I'm sorry to hear that about your family. I think pancreatic cancer, it tends to be diagnosed at a more advanced stage, and that's why one of the factors that contributes to its poor prognosis. Symptoms can kind of be quite vague and kind of missed for other things. I think that some patients may present with some abdominal pain or pain after eating, or potentially, a little bit of weight loss, and may not have, specific symptoms that point to a diagnosis of pancreatic cancer. What's been your experience, Rick, with patients presenting with pancreatic cancer? What are some of the kind of clues into thinking about this in your differential when someone comes to you?
Yeah, to your point, I think a lot of it, unfortunately, it's detected at a later stage because in general, there's not a lot of innervation to the pancreas that typically would trigger pain symptoms until the cancer gets to a significant size. So usually what we're seeing is either kind of vague abdominal pain symptoms, or if a patient is potentially a little more fortunate, sometimes the mass can block the pancreatic duct, which then can lead to things like jaundice, which is yellowing of the eyes or yellowing of the skin, or other signs or symptoms that would trigger a workup of that area. So, it's very, like you mentioned, it's a very variable presenting disease. There's people who just come in with sort of weight loss of unknown etiology, who then turns out it's all because of a pancreatic cancer. So it's definitely a tough one to diagnose. I know that they've looked into screening programs or things like that. And, unfortunately, because it's not the most common type of cancer, it probably, based on, what they've shown, is screening everyone for it doesn't really make sense because the incidence itself is relatively low.
Right. And Some of the risk factors for pancreatic cancer include smoking, although that risk is fairly small. Increased BMI or obesity can contribute to a risk of pancreatic cancer. There are some exposures to chemicals, heavy metals that can increase your risk of pancreatic cancer, as well as heavy alcohol consumption. And those patients who may have a history of alcoholism who end up with inflammation of the pancreas called pancreatitis do have a higher risk of pancreatic cancer, as well as those individuals with diabetes. And, diabetes can be a risk factor for pancreatic cancer amongst other cancers. So these are some of the risk factors, although, I've definitely seen patients without these risk factors who do get unfortunately diagnosed with pancreatic cancer. And I think, Rick, you're right in terms of the screening that we can do for this. Really, I think the only thing that might hold some weight in screening would be doing like an endoscopic ultrasound, but it is a procedure. It's not a simple, image that we do for patients. MRI imaging has been thrown out as a potential screening measure, but nothing's kind of held up as an effective screening for this. So I think, being in tune with your body and, picking up on subtle symptoms early and getting checked out, especially if you have a family history, because this type of cancer also has a little bit of an inheritable risk with patients who carry mutations. Yep.
Yeah, I think it's like one in 10 they estimate is associated with some sort of genetic predisposition. So certainly, like for myself with a family history or others with a family history of pancreatic cancer, certainly do not put to the side any signs or symptoms that, could possibly be related to such a thing.
Right. And it seems with the risk factors, how do we prevent pancreatic cancer? Well, it's kind of leading a healthy lifestyle. Obviously, that's not going to prevent it in a majority of people, but it is something that can lower your risk of diabetes, lower your risk of the effects of obesity, et cetera. So always a good idea.
Right. And I think, there's this, these international guidelines getting back to the screening question and sort of prevention, I guess, too, is for high risk individuals. So, first degree relatives, if patients with pancreatic cancer, known patients with certain mutations, like BRCA mutation, P16, certain other clinical syndromes. Those are the groups that really, are the ones that I think we would all say should at some point have a screening, like you mentioned, EUS or MRI, to just make sure there's nothing hiding, because we'll get into it shortly. But, if caught early enough, pancreatic cancer is potentially curable. The issue is just, of course, catching it early.
Right. I think catching it early does give really the only chance of long-term survival. So catching it before it's spread to somewhere else in the body is really key here.
So do you want to talk about sort of generally, Danny, or I can, kind of how you approach when we look at pancreatic cancer from maybe a localized, smaller disease, maybe a more locally advanced disease, and then maybe how do you approach, pancreatic cancers that have already left the pancreas and spread to other areas of the body?
Yeah. So when I learned in fellowship kind of how to approach a patient with a new diagnosis of pancreatic cancer was looking at, one, are they a surgical candidate or not? And that's kind of determined based on how the tumor is sitting in the pancreas, where in the pancreas is the tumor, and is it next to major blood vessels or even wrapping around blood vessels, which may make surgery not a good option for a patient. So you kind of decide up front, is the patient a candidate for a surgery based on the location of the tumor and whether it's involving blood vessels.
What does the pancreas do, Danny, in a normal person?
Well, in a normal person, the pancreas really aids with digestion of food. So there are cells within the pancreas which produce enzymes, which helps the body break down food into energy that we need to, help our body function. There are also other cells which produce hormones, and these hormones have a variety of functions in the body. Things like insulin and glucagon and those type of things, which help regulate blood sugar. So it has a lot of very important functions.
And I think it's why sometimes, when we'll get into this a little bit, but if a patient has surgery to their pancreas and it gets removed, they're almost most likely going to have diabetes because, as you mentioned, one of the major endocrine functions of the pancreas is to regulate insulin levels in the body.
Correct. Yeah. When we're approaching a new diagnosis of pancreatic cancer, again, we're looking at where the tumor is located in the pancreas, how big it is, what are the structures around it, and is the tumor growing into those structures? And that really determines whether the patient is a candidate for a surgery or not. So we first need to determine, can we do a surgery safely based on location and size of the tumor? And then it's best to have these discussions in a room with surgeons and radiation oncologists like yourself, Rick, where we can come up with a plan all together on how to approach the treatment, because it really does take all three of us, surgeons, radiation oncologists, and medical oncologists, to treat patients with pancreatic cancer. Now, there are some times, and I know, Rick, you're going to be surprised by this, but they may not need you. They may not need radiation treatment.
So he kept.
That's correct.
And I hear Dr. Tanzler in the background again. She really wants to be on this podcast, doesn't she?
Sorry, guys. This is what happens when we try to record in the middle of a clinic day.
I know. I'm just kidding. So determining whether a patient's a candidate for surgery is what we first make our decisions on next steps of treatment. So if it's a small tumor and it doesn't look to be next to any vital structures, a surgical oncologist may bring the patient directly to surgery and remove the tumor. A lot of the cases, though, we see are patients with a little bit of a larger tumor, maybe close to blood vessels or other structures, which make a surgery up front kind of difficult and more risky. And so we, in those cases, decide on giving patients some chemotherapy prior to surgery, and sometimes incorporate radiation therapy as well.
I agree.
So these patients, in the past had been using chemotherapy that was sometimes just a single agent chemotherapy. There was some recent data that come out that actually shows a combination of chemotherapy drugs by an acronym called FOLFIRINOX can be more effective and potentially lead to more cures in the long run. And so we typically use this combination chemotherapy either before or after surgery in patients with pancreatic cancer.
So I like to break this down, as you know, kind of big picture.
Yeah.
So the first, like you mentioned, the first step is this someone that can go to surgery? So, medically, is the person healthy enough? And then the second piece being, is this tumor resectable with a good chance of removing it all? And I think the reason pancreatic cancer is so devastating is, even if it's diagnosed early, there's still a high risk that there could be microscopic cancer cells hiding elsewhere in the body. So the role of what you do with chemotherapy is vitally important, because what you're trying to do is minimize the risk of new sites popping up outside the pancreas. So that's why, to your point, it's given before or after surgery. I think, and correct me if you feel differently, Danny, but I think the push nowadays in general is, even if the tumor was upfront resectable, I still think, there'd be strong consideration to giving the multi-agent chemotherapy first, and then following it up with surgery on the back end. I know there's other ways to do it with the surgery first, but I think that's kind of where I would recommend most patients go. Unless it was just truly a small little tiny spot they could easily remove.
Right. Yeah. No, I think nowadays what we call neoadjuvant or preoperative chemotherapy is what we do for most patients, as long as they're healthy. You pointed out kind of what's the health of the patient before, and usually it dictates whether they're a surgical candidate. But we like patients in good enough shape for surgery and chemotherapy. There are some overlapping, kind of assessments that we do to determine whether patients could handle the chemotherapy and could proceed with surgery. So, but yeah, I think in a majority of cases, we're doing it preoperatively just because, or before surgery, because then we can kind of see, one, if we can shrink down the tumor a little bit, but two, also try to prevent or kill off any cancer cells which may have snuck off from the pancreas and are trying to travel elsewhere in the body.
Exactly right. And to your point, the role of radiation certainly has changed over the years. I think, my role now would be really in a situation where preoperatively the patient got chemo first, still was potentially a surgical candidate, but the surgeon felt maybe adding some radiation prior to surgery would increase the chances of them removing all of the tumor. The other times that, usually radiation gets involved in the definitive setting is if the patient has a surgery and there's a positive margin or residual disease or high likelihood of residual disease, and they've already completed chemotherapy and there's no other areas of disease. I think in those situations you could consider giving radiation to where the pancreas used to be.
Yeah, I think, what the summary kind of for how we approach treatment nowadays is that a majority of patients will receive chemotherapy if they're a candidate for treatment. And that's either before or after surgery. But as Rick said, we're leaning toward giving chemo before surgery in a lot of cases. And that holds true too for patients who, unfortunately, if you're not a candidate for surgery, we usually do start out with chemotherapy to try to shrink the cancer and try to prevent spread. But just to kind of reiterate, the only cure for pancreatic cancer, with the exception of some outliers and rare cases, it's going to be surgery and chemotherapy.
Exactly. Yeah, there's certainly, a lot of interest in my field of, can we give, higher doses or more biologically effective doses of radiation to the pancreatic cancer? So there's a lot of trials looking at this, and certainly some exciting results in certain patients. But those are really only going to be for situations where surgery is off the table, either because the patient isn't strong enough to get the surgery, or the disease is too advanced to be removed.
I saw a really rare case in fellowship, Rick, where it wasn't a patient I treated, but I inherited the patient, and the patient had, I think, locally advanced pancreatic cancer, meaning it was in the pancreas and probably in some lymph nodes. And patient got chemotherapy and ended up having a really nice response to chemotherapy, then got radiation treatment to the pancreas and I think the surrounding lymph nodes, and then was cured of pancreatic cancer. I've never seen a case like that before.
Yeah, I have probably two patients that I can think of that couldn't get surgery that we've given, like I said, kind of that more aggressive ablative level radiation dose that are several years out with, knock on wood, no evidence of disease coming back or new disease popping up after the chemotherapy and kind of more aggressive radiation. So I think it's one of those things in the future we may, find there's a subset of patients that are potentially curable. But the bottom line is, as usually, and it does happen, but the usual form of cancer recurrence for pancreatic cancer is distant, so outside of the pancreas. There are patients that do recur in the pancreas, but the majority of recurrences are outside of the pancreas, and that's what makes it such a lethal disease.
Well, we'll talk about some treatment advances lately in pancreatic cancer. Unfortunately, from the medical oncology side, there haven't been a lot of advances. One of the advances, though, is targeting BRCA mutations with a drug called olaparib, which is a PARP inhibitor, and this is now FDA approved to use in patients who have stage 4 pancreatic cancer who have completed chemotherapy and still are having a nice response, that you could use this oral medication, which is only really effective in those patients with BRCA mutations. And you can give it as a maintenance to try to maintain the remission to extend patients' lives longer. It's not a curative treatment, but it does, I think, lengthen survival, and it's fairly well tolerated. So that's one of the advancements in the recent year or two that's come out. Otherwise, there are some targeted therapies that have overlapping indications, but we're talking most of these therapies are used for patients with metastatic disease or stage 4 cancer. And it's a really low percentage of patients that have certain targetable changes in the DNA that we can target with drugs for pancreatic cancer. So I think a lot of progress needs to be made so that we can hopefully cure more patients and also lead to better overall survival for these patients.
Completely agree. I'm back.
Hi.
He's back.
What's
back
happening?
again.
We were just talking
Dr.
about
Rick's
So-
back.
how we block their schedule, how we block your schedule and it's never blocked.
I was going to say, Brenna, did you see what happens when you block my schedule? It really is blocked effectively.
I swear to God, I block it. I swear to God.
The block gets blocked. That's what happens. It's like, yeah, right. All right, Rick, I think we covered a lot of good information on pancreatic cancer and some good things for our listeners to look out for, and some information on the diagnosis and some of the overviews on treatment. Any final thoughts you had?
No, I think we covered it. I mean, I think it's one of those diseases that, like I said, is obviously on the minds of a lot of lay people as well, just because they know it's one that if you have it, it's a very, unfortunately can be a very deadly disease. So I think it's just one to be aware of the different signs and symptoms. And certainly if you are worried at all with any of the things we mentioned, don't hesitate to contact your doctor and get it looked at further.
All right. Thanks so much, guys, for coming back and joining us for another episode of the Medical Minute.
If you have any suggestions on things we should talk about, questions you'd like answered, or you just want to say hi, please email us at medicalminute@csnf.us.
And make sure you follow us on social media and search Cancer Specialists of North Florida on Facebook and _CSNF on Twitter and Instagram.
As always, we appreciate you giving us a few minutes of your time, and we hope you learned something today.
And remember, when it comes to your health, stay informed.
Ask questions and
tune in next time.
I had a feeling the digital version of this would be a little tougher.
Turn your cameras on to do it real fast.
Oh,
I don't have a camera.
My laptop's not up. I can't do it.
I don't have a camera.
And
All right.
Tune in next time.
All right, try again.
All right.
Just the last
And remember,
part.
when it comes to your health, stay informed.
Ask questions
And
tune in next time.
You're going too slow. Come on.
I'm not going slow. I'm going at the pace we normally do.
All right, I'll slow it down. And remember, when it comes to your health, stay informed.
Ask questions and tune in next time.
We need to look at each other. That's the problem.
Just try it one more time.
And remember, when it comes to your health, stay informed.
Ask questions and tune in next time.
All right, that's fine.